Hello, and thank you for joining today's webinar. Today we'll provide an overview of effective strategies to help transform your emergency department performance and improve clinical documentation. My name is Bryn Birchfeld, and I'm T-Systems Marketing Specialist. If you have any questions you'd like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar, or type in your question in the chat box. At the end of the session, we'll gather your questions and try to address as many as time permits. If we don't get to your question, please email us your question at info@tsystem.com. I will send a follow-up email of the webinar recording for you to view later or share with anyone who is not able to attend. Our presenter today is Janie Schumacher, Chief Nursing Officer at T-System. Janie drives the development of T-System solutions that improve clinical quality and patient outcomes. She uses her expertise to recommend clinical and industry best practices to help clinicians better drive more efficient care in a busy, evolving, unscheduled care continuum. And now to kick off our presentation is Janie Schumacher.
Hi there. Thank you, Bryn. Thank you, everyone, for being with us today to hear about how to transform your emergency department and improve clinical documentation. It's a pleasure to be here to talk with you today. I know your schedules are all very busy, so I appreciate you taking the time out. And as Bryn said, I'm going to go through this and save enough time for some questions at the end. So please feel free to submit those as we go along, and we'll be sure and get to as many of those as we can. What I want to talk to you about this morning is why, a case for transforming the emergency department. Why would we talk about that and need to do that? And then I want to go just at a very high level to give you a couple of sample case studies from some of the work that my team and I have been doing around transformation services in an emergency department and clinical documentation improvement. So ED transformation, let's talk about making the case here a little bit. And when we think about the word transformation, we think about a thorough or dramatic change in form or appearance. And with the healthcare landscape the way it is right now, I really believe that emergency departments have to take a hard look at how they do what they do and how do they contribute to their organization in a positive way. And with so many things competing for our time and attention throughout our organizations, the emergency department really needs to run more efficiently and effectively than ever before. So the time is now to take a hard look at what we're doing and see where we have opportunities to improve. It's critical that our emergency departments meet and exceed our customer expectations, and we'll talk a little bit more about that in just a moment. It's also critical that we in the emergency department contribute positively to our organization's bottom line financially, as well as when we think about things like downstream effects like patient expectations, customer expectations, how we can help drive our organization's HCAP score, downstream referrals, and subsequent visits. At T-System, we have a very vast understanding of what you're dealing with day to day. We understand that the landscape is extremely challenging and time is short, and sometimes best intentions get waylaid by other things going on. T-System is in over 40% of the emergency department market, so we have exceptional clinical leadership and industry expertise. We live and breathe this every day just like you do, so we understand what your challenges and constraints are. And so as we come alongside you with some of these solutions that we have a deep understanding of what you're going through. Some of the things that compete for your time, of course, are consumer expectations. Everybody wants to have their fair share of the market. We've all got plenty of regulatory and reimbursement challenges that we struggle with every day. Leadership bench strength is a huge factor as we think about some of these things. We have to have effective leadership to carry out any kind of improvement or daily operations that we want to achieve and sustain. We'll talk a little bit more about that one in just a moment. Effective leadership is going to have about a 70% effect on workforce engagement. We've all got a board of directors or a boss that we answer to, and they've all got expectations that we're trying to meet and exceed. Some of us have corporate expectations or a system that we answer to on top of that. And then we're all trying to figure out what our strategy is, and many of us know what that is. How do we achieve the results and sustain the results to go with that? So the time to transform is now. Let's talk a little bit about this. I like to kind of break these out. We're dealing with a moment in time like never before. I refer to it as the silver tsunami. And by 2029, 1/5 of our U.S. population is going to be 65 years or older. That's going to put a significant strain and change on healthcare. There's going to be a lot more people needing healthcare at higher levels, higher acuities, and there may be less people to provide that because many of the folks that are going to be joining this population are going to be retiring from our ranks. Another way to think about this is that 10,000 Americans turn 65 every single day, and this is going to go on for 20 years. That population is what we know of as the baby boomers, and the baby boomers have been very effective at being able to redefine segments of their life as they've gone through, and healthcare will be no exception. Baby boomers are going to be changing the way we deliver healthcare, and their expectations are going to mold and shape some of the things that we'll need to do. And that brings us to consumer-driven care. We're getting a lot more transparent. People can look up things on the internet and know much more about ourselves and our organizations than ever before. And they'll make decisions based off what they see and what they hear. Regulatory and payment reform, we're definitely going away from fee-for-service to more value-driven forms of payment. Regulatory requirements certainly have not come to a halt. We're all accountable to somebody, whether that be someone like the Joint Commission or CMS. And so we've always got to be on our toes and on top of regulatory compliance and struggling to meet expectations and rules around payment reform. Obviously, there's a huge technology explosion. So people have a lot more access to data, and they expect a lot more from us. Stiff competition for market share. This is why transformation is so important. People, when they come to our emergency departments now, they expect that we're going to be clinically competent. They want the rest of the package to go with that. So they want human connection. They want information. They want to be kept informed. They want to be treated as though they're special to you. And of course they are. And sometimes that we have opportunities to deliver that message to them a little more effectively. So the emergency department really has to be a well-oiled machine, and we have to be part of the solution going forward into the future here. So as we think about transforming our emergency department, I hear a lot of arguments about, you know, we're not a hotel, we are a hospital, and I actually agree with that very much. I am not asking or suggesting that any of us turn our emergency departments into hotels. I think that is not what we do. But what we do need to do is be sure we have sharp leadership skills so that we can carry out the improvements and objectives that we need to meet. We do need to focus on the human connection. So while we're not trying to be a hotel and leave mints on the pillow, there's a lot to be said for making sure we have effective communication, streamlined operations, and keeping these people informed and making people feel like they are the most important person in front of us right now. And also, we need to continuously be looking at our operations for gaps or bottlenecks in those and continuously improving. And that is one good start to transforming our emergency department and making sure we meet and exceed our customer expectations. So one of the things we focused on, my team and I focused on a lot, is what we call our success hierarchy. We believe that all things start with effective leadership. So my team and I work with organizations and leaders quite a bit to make sure that leaders have the skills that they need to achieve and sustain results in their emergency departments. And my team and I have all done these kinds of roles and spent many years fine-tuning these things. And basically what we're looking at is cast appropriately leaders that are in the right spot, that have the right skill set, that have the right development and support to be successful, and that they're empowered to do so. And there's some very specific leadership principles and tactics that my team and I come in and assist and teach and coach when we're on site with an engagement. Effective leadership not only drives results, but it's critical to workforce engagement. You can't achieve sustainable results without your workforce being engaged. And as I said a minute ago, leadership accounts for nearly 70% of the variance in workforce engagement. And how we drive workforce engagement are other things that we coach as we come on site with our services, and that is through talent differentiation with critical conversations, transparent, honest communication, and pushing decisions to the lowest possible level and development of that workforce. And that, if we have effective leadership and we have good workforce engagement, then we're really able to drive results and success with measurable outcomes that we're all looking to achieve. So let's talk a little bit now about what kind of services we offer and what those look like. I'm just going to give you a couple of examples. What we like to do is get to know our organizations very well so that we can provide a customized approach to whatever kinds of opportunities that you may have there at your facility. We do this because we want to impact care providers in the care environment to enable the best possible experience for patients and their families, while in turn maximizing clinical, operational, and financial outcomes. This is all done because we know that there are patients and families on the other end of the care, and that's the most important thing. But we also know that we have to take care of our leaders. Being a leader in healthcare right now is very challenging and is definitely not for the weak of heart. So we have to make sure that our leaders have the right skills and tools. And T-System, our clinical services team, has some very effective tools that we teach. And that drives results and performance so that the patients and families get the best possible experience. And at the same time, we want to be sure we're maximizing your clinical, operational, and financial outcomes. Oftentimes what we find, and you'll see this as we go through this case study, is, and this happened to me, when leaders are chosen in the organization, it's often because they were very good at what they were doing in the job before that. So now they're asked to step up and take the next role. And that was definitely my experience when I was a new leader many, many years ago. I had been a really exceptional emergency nurse. I had served as a charge nurse, and I was very, very good at patient care and leading shift to shift in our emergency department. And then I was asked to become the nurse director, and I was very ill-prepared for that. So I have a real soft spot for our nurse leaders out there. So we do a lot of work to try to help get some good skills in place there so that people feel less stressed and more equipped to handle what's in front of us today, because these are not easy jobs. So let's take a look at what we call our performance assessment. This is where we go in. This is where we come in and take a look at, do a real deep dive into an emergency department operation. It's an in-depth assessment of the emergency department. We look for opportunities in all areas. So we look at your workflow. We look at regulatory compliance. We do a documentation review to go along with that to see how documentation looks. And then how is it being deployed in actual practice? So do we have patient safety goals, for example? Are those being met in actual practice? Do the policies and procedures match what we're seeing? Patient safety, same thing. Do we have gaps in patient safety? Do we have opportunities to improve there? Patient experience is a big one because we all want to keep our patients safe. We want our patients to have the best possible experience they can because we want good word of mouth. Good word of mouth is the best marketing tool out there. It's better than any billboard or ad that you can purchase. And consequently, core word of mouth is also quite effective when you think about getting that market share for your organization. And then we focus heavily, as I've been talking about, on leadership development, because we believe strongly that the leader that's in place, or the leaders, sometimes it's one, sometimes it's a team, depending on the size of the organization, have to be well equipped to handle what's in front of us today. So we do a real deep assessment, and we create our findings, and then we sit down and we share those. So one of the places that we've worked with, I'm going to keep them anonymous for confidentiality, but just to kind of give you an idea, we've worked with a place with 35,000 visits. They recently renovated their physical space. They had a dated emergency department, and they thought renovating would conquer a lot of their workflow problems. They were struggling with market share. They had sort of a unfortunate reputation in their community, low patient satisfaction scores. So they really thought their renovation would help with quite a bit of that. It did not completely fix all of that, and they were concerned about losing a portion of their reimbursement and market share. Their ER visits, they figured out, were affecting their hospital HCAP scores. And many of you probably know that if your patient has a bad experience in the emergency department, even if everything else goes well in the hospital stay, patients are much more likely to give you a lower score on HCAP because of that negative emergency department experience, even if everything else goes well. So a positive emergency department experience is what we're shooting for, so that we can get the best possible scores on HCAP. And we all know that our reimbursement is now 30% tied to those HCAP scores. EDCAPS is on the horizon. We felt like it was coming out in 2016. That may get pushed, but we do know it's coming, and it will also be tied to reimbursement at some point. So it's important now for emergency departments across the country to get their patient satisfaction, patient experience on the right track, so that you'll be successful when EDCAPS does come into play. And this place, their ER leadership had also turned over several times, and that's pretty common across the country. At any given time, there's about a 35 to 40% vacancy in ER nurse leaders. And that really puts a damper on being able to achieve and sustain results when you have a lot of leadership turnover. It's hard to get momentum. So this particular organization promoted one of their charge nurses into their ER nurse director role. So our work looks kind of like this. We do some preparation work. We ask for some data. We analyze that. We have a meeting with C-level and other key leadership around the emergency department, so that we can understand what goals want to be achieved, make some recommendations, and set some expectations for the work at hand. We do our on-site evaluations. We did here. We interview leadership and other key stakeholders. We spend several days on site making a lot of observations on different shifts, looking at workflow, looking at processes, observing patient care, and looking for any patient safety or regulatory gaps that we may get in trouble with later on if we have a survey or something that we think could be lying in wait to create a patient safety issue. And then we provided our client with findings. So we sit down again and we go over those, and we make some recommendations and an action plan. And then we moved on with this client for some additional work. So what we found is that this charge nurse who'd been promoted had very little leadership experience other than what she got as a charge nurse, and she was struggling with mitigating some performance gaps. We found some bottlenecks in the workflow, a very lengthy upfront triage process, many people in the waiting room, which never makes anyone happy. You know, it's a very let's get it done right now society that we live in, and certainly emergency department care, while it can't always be that way, consumer expectations are no different than anything else. Let's get on with this is what they all want to do. Admitted patients here were waiting far too long for transport to the inpatient unit, so that was creating some back-end bottlenecks. We found several regulatory and patient safety opportunities. For example, dual identifiers was just not being utilized at all, so we when they did medication administration or labeled laboratory specimens, for example. So we felt like that was not only a regulatory item that would be found, but it was also a huge patient safety opportunity. And I'm sure we've all got some stories about mislabeling of specimens or medications going to the wrong person by accident that we could share. Patient experience. Patients really didn't feel like they were being kept informed. The satisfaction survey results reflected that. And we noticed when we watched nurses and techs specifically, they needed some some behavioral, some soft skill improvement, and some rounding practices that needed improvement. And those things are budget neutral, and they're very easy to shore up. Well, I shouldn't say easy, but they're definitely doable to be able to shore up. It just takes a little bit of work. So we went back with phase 2 of our transformation service and prioritized what we wanted to work on first, working with the nurse leader and the medical director. We're very collaborative. We believe in involving all the key stakeholders. We want to get engagement and buy-in so that we can drive results and not only achieve results, but sustain those. It's very easy for any of us to hit the target once, but you want to sustain those over time. We believe in side-by-side support when we roll out this kind of improvement work. It's easy to put a plan in place, but we believe that side-by-side coaching and support works best for sustainability as we go through deployment. And then we infuse evidence-based leadership skills into the key leaders, and that gives them the skills and the confidence and the knowledge that they need for long-term success. So that's what our performance assessment looks like. It's very customized to the facility that we were working with, and so we're still working here, but we've had some very good gains and more to come on that as we continue with that organization. So switching gears then, I would like to briefly cover our other service that I wanted to talk about today, which is our clinical documentation improvement service. We believe that very much that when we talk about this, many places have this kind of a program in their inpatient units. That's really been the focus of where CDI has centered. We very much believe that we want to make sure documentation of care provided is in the record. We want to make sure that we're audit and regulatory defensible. And we want to make sure that we are improving charge capture and revenue for the organizations that we work with, because I don't think any of us have a lot of bandwidth to leave money on the table these days. CDI in the emergency department can be a challenge. As I said, it's often overlooked because the emergency department is a busy and chaotic place. It's very difficult, if not impossible, to do a concurrent chart review and really catch things as they're in the works. Training needs are very extensive, and especially with ICD-10 coming out now. Now we've just expanded the amount of codes exponentially, so we've got even more burden on our shoulders now when we think about teaching our physicians how to document. ED physicians can be difficult to reach for chart queries because they work shifts. And a lot of our electronic health records don't come with standardized content to guide effective documentation. So people sometimes end up just doing the best they can in a chaotic environment. And sometimes we suffer from the idea of good enough. So sometimes if we're getting revenue in the door from our emergency department and the documentation looks okay, we figure that's good enough. And so a lot of times we kind of walk away where we could have made some significant gains, but we just sometimes don't have the bandwidth to tackle everything. So that's why we're here to help you. So again, another one of our organizations that we've worked with had some reimbursement challenges, as I think we all have, and they began to analyze every aspect of their business. Documentation, coding practices in the ED, they hadn't looked at those for several years. they wanted to see. Do we have an opportunity to improve revenue in this setting, or don't we? A little bit more about them. They were a Cerner client. Their providers had scribes. They did their coding for both in-house and professional, and they'd had very high nurse turnover in this particular site, and Cerner FirstNet was what they used for their nurses, and their new hire training wasn't well deployed. So nurses were kind of guessing also at what to document. So just like the other service, we like to do our homework. We like to get to know our organizations very well so that we feel prepared to make some good recommendations and understand you and what you're going through. So we do some preparation work. We do a chart review with this service, and then we provide the findings from that chart review, or assessment as we call it. And it kind of looks like this. We like to always make sure that our leadership is on board. We will do a, make sure our paperwork is in place, because we do need to access your charts to be able to take a look. This is really a documentation review, looking at what your nurses and your doctors are actually documenting, and how can we improve on that so that you get not only a great patient story being told about the care provided, but also make sure you're not leaving any revenue opportunities on the table. So we complete our chart review, and I know this middle arrow is kind of busy, but we're looking for things like true severity of illness and risk of mortality. We're looking for the presence or absence of codable terminology. We're looking for present on admission conditions, hierarchical condition categories. We're looking for IV hydration and timed infusion procedures, and we're looking for ICD-10 specificity. We also want you to be very successful on your quality metric documentation, and there are a few of those that the emergency department can be very helpful with, so we make sure that you're hitting all of those. And then we take a deep dive into your nursing documentation from purely a regulatory, safety, and risk reduction standpoint, so that your documentation will be more successful when you have surveys, and make sure that your patients are getting the care that they should have. And then we provide, those findings back with some recommendations for improvement, a projected return on investment. And then in the case of somebody wanting to move forward, we'll talk about that in a minute, but this particular facility, we always like to point out what's going well. So these are a few things that we found, not all of them. This is just a snapshot of some things we felt were going very well there. They were doing a great job with care handoff, transfer to the next level. They documented their consultations well. The documentation of the care provided consistently matched what was ordered. And believe it or not, we often find things were ordered, not documented, things were documented, not ordered. So in this case, this site did very well with that. They did well documenting the chief complaint, the history of presenting illness, describing the patient's reason for visit, all those things important. And in the EMR they were using, free text was discouraged because there were so many, the content was robust. So we didn't want to see a lot of free text here, so they didn't use that. So these are just a few things that we found that were going well. Some opportunities that we found here, documentation of the review and agreement with nursing notes, documentation of past medical history with specific conditions instead of general disease processes. All these things sort of build on the patient care story and help us as we go to code for things. So we may be leaving some dollars on the table when we don't describe these things or document these things well enough. Conflicting documentation can be a problem. We did find some of that here. Capturing pre-arrival clinical information and treatments administered was a problem here. We had some quality metric issues with timely ordering and review interpretation of CT for head, especially with stroke patients. And we found that there was zero sepsis screening going on, so we were not getting on top of those sepsis patients at this site in a timely manner. And this next slide is just sort of a snapshot when we think really about CDI. This is just one patient I took out of the review. This just kind of shows you what we observed, what the potential was. So We observed pneumonia organism unspecified being documented. The potential here was to document pneumonia suspected gram-negative. Same with the secondary diagnosis, just getting more specific, using more codable terminology, and you can see your relative weight goes up, and you can see kind of how that plays out. So these are the kinds of things. This is, like I said, a very extensive dive into the documentation, and we'll provide very specific examples around these kinds of things that we find. We also found with nursing lots of missing IV start and stop times, so they were losing all that money, missing assessment notes and interventions, so they were having more difficulty building the E&M facility level that they should have been getting. Incomplete or missing procedures, and there are a few in nursing that count that we need to make sure we get right. They had several missing regulatory required elements there. We also noted that there was a little bit of undercoding going on with aspects of the provider documentation. A little bit more on that regulatory and safety. We did figure out for patient safety a documentation of an acuity. Triage acuity was missing here 36% of the time. And of the patients who did have an acuity documented, 56 of those were found to be incorrect. And so what we figured out was this facility was under triaging. So that's a big concern, because we may have patients who are sicker than we think they are. And if we ask that patient, or we have to have that patient wait, that can be a big patient safety issue. So we did come to figure out for this client the financial impact. 55% of the records reviewed had potential change in DRG identified. There was a total increased revenue reimbursement potential just in the sample we looked at of $119,000, almost $120,000. The average increase in revenue and reimbursement per record was about $4,400. And so based on their population, and this is not a large site, but based on their population, the amount they're leaving on the table is just a little over $500,000 annually. So how we're going to address that with them is through some training and some on-site support, and some weekly review of their progress and their charts, where we work with our client here to identify what we want to tackle first based on the return on investment. We do some training with the nurses and the providers. Some of this we do remotely. The training we do on site. Some of the support we do remotely with weekly feedback to talk about progress. And we have a champion on site that helps us get the feedback to the physicians and nurses. And then we continue to monitor that remotely. And then we go back on site with additional training and support periodically. And then we keep sort of a running scorecard about how the client's doing, what kind of gains they're making. There's nothing worse than somebody telling you that you've got $500,000 on the table, and we do some work, but you never really figure out if you got that or not. So we like to make sure that we track progress to make sure you're getting your return on your investment, and that everybody can understand that. So in summary, these are some services that T-System has. I'm very excited. My team and I absolutely love this kind of work. So we want to take some time to share some of this exciting work that we're doing with you today. And I'm going to turn it back over to Bryn, because I know we're about out of time, and see if there are any questions.
All right, thank you, Janie. We have time for a couple of questions. First question is, regarding CDI, how does this work if we already do CDI on the inpatient side?
That's a great question, and many places do already have an inpatient CDI program. So we definitely don't want to work against that. We want to work in tandem with that. So we will come alongside your inpatient CDI program and collaborate. And oftentimes, especially patients that are going to be admitted, we can make a big impact into the CDI person who's working on the inpatient. We can make a huge impact into their workload by being able to shore up some of the things that we need to document for the emergency department. So it's a collaborative effort, and it works very well putting the two together.
Okay. We got time for one more question, and that's, our ED could use some help, but of course we are limited by budget. Are these things you can do to help us that are effective and budget friendly?
Yes, the answer to that is yes. We work with anybody in all budgets, so don't be afraid to reach out. We can definitely talk about an approach that is budget friendly for you and that can be very effective at the same time. So please don't hesitate to give us a shout.
Okay, well, thank you everyone for joining, and I will send out a recording of this webinar. And if you have any questions, please contact us at info@tc